Thank you, Kim, for covering the easy part of the presentation. I get to talk about the challenges and lessons learned in more detail, and I will start off by saying that a tremendous amount of work went into developing this process, and I will highlight a little bit of that, but in my presentation, we're going to focus on how we sort of developed the commitment to do this, and then how we rolled this out in retrospect as a change process, although I'm not sure we necessarily thought about it as that kind of a construct. And I will propose that as we move forward and develop new programs or improvements in medical education, one of the lessons I believe we should learn from this rollout is it's always a change process. There was something before. And that something before, for as good or bad as it was the normal. So we were not just rolling out a new thing, but we were changing. And I believe that construct will be important for us to remember as we make future improvements. So by the end of this session, you will be able to define the process required to develop a change commitment to a multi-assessor system for direct observations of competence. Define the faculty development challenges in such an implementation, and then propose a detailed change process kind of construct to guide successful implementation of any new system in medical education. So I like this decision-making model. This is from the University of Massachusetts, Dartmouth, and there are multiple models in the literature, but as I reflected on our decision to move ahead with a new system of multi-assessor assessments of our students, we really made this kind of big decision. And in this decision-making model, it starts with identifying the decision to be made, gathering information, identifying the alternatives, weighing the evidence, and then choosing from the alternatives, then taking action and reviewing the decision. It's certainly a model, but as we go back and look at these models, I believe we can think about the process that is inevitable in developing a change in something we do in medical education, and perhaps be more thoughtful about where there's opportunities to do it better. So, for example, identify the decision to be made. Well, the competency-based design that we developed for the new curriculum, really, it was incumbent for us to develop a more robust assessment system. And the decision to pursue multiple assessments for multiple evaluators over time is very much driven from the type of curriculum that was developed. As Kim said, prior to 2015, many assessments were done on paper. And we realized that as we started increasing the number of assessments and the number of observations over time, we were going to be buried in paper, as well as have some of our tree huggers be even more concerned than they already will. And in reality, we weren't looking at that paper very well. So the decision in terms of to be made was we were going to do a digital solution. So what was the robust digital solution that would enable more frequent and accurate assessments of students in clinical settings? Gathering the relevant information includes, in a way, a request for application or a needs assessment. You can think of it in either domain. But what we landed on was we wanted a multi-platform process that would be applicable to smartphones, tablets, laptops, PCs, Macs, because we have over 1,700 faculty. And if we were going to go and say this is an iPad way, we could guarantee that a third of our faculty would tune us out. And if we said it was going to be a Mac way, it'd be 80% of our faculty would tune us out. So recognizing the heterogeneity of our faculty, we needed a multi-platform process. We needed something where our coordinators could be integrally involved in developing the forms and the questions and assignment creation, because we knew it could not be done from a central office, and we knew our faculty wouldn't do it. So we needed something that our coordinators could operationalize with the proper training and engagement. We also knew that our faculty and students were both going to have skin in this game, that they were going to be involved in helping us develop and test the reports, and the question types. And ultimately, as I will show you, we landed on a process that involved both student-directed as well as faculty-directed observations. And then, of course, since at Ohio State we never decide on any single thing, we decided we needed multiple assessments. So we needed a system that would provide yes, no, Likert scale, multiple choice, multiple selects, narratives. We wanted it all, as befits a university with over 55,000 students. You know, nothing can be simple here. So I'll move to step 5, which was choose among the alternatives. And I think what really informed us in this part of the process was thinking about sort of more additional requirements, I would say, things that were desirable but go beyond those basic. So for example, because of the curriculum that we were developing, we recognized that we'd like to ultimately map these to competencies and milestones. We also wanted a system where we could interrogate the system for reports. We didn't want a system where we were going to have to be dependent on others to generate the reports for us. And we wanted it to be usable and customizable so that they could be done by multiple members of our faculty as well as our teams, so that, again, it's not run through a central office. We, of course, wanted some level of reasonable security, recognizing that nothing's perfect. We, of course, wanted stellar customer and application support because in the past we've not had stellar and robust customer service support, and we recognized what a lesion that is. And then, although we did not have a defined budget, we said not too expensive. But we recognized that this was going to be an important investment and really, again, part of that decision to have a competency-based curriculum. We landed on Myprogress, and we believe that Myprogress could deliver on those multiple sort of additional requirements beyond our basic requirements. And I would say so far we've been very happy with what we've been able to do. And what we've come to recognize is that if there are any areas for improvement in what we've done so far or what we might think about doing differently in the past, about 90% of it lands with us, not with Myprogress. And again, I think a lot of it goes back to a change process and how complex it is in these kind of complex systems. You know, the analogy is, we were sort of constructing the Boeing 747 as we were flying it. There was a little bit of design work before it took off, but as Kim said, we had a whole 2 months of pilots. Wow. And then we rolled it out in one clerkship, one area. No, we rolled it out an entire, and you saw all those rings. So by now you should be a little dizzy or maybe a little queasy after lunch with all the rings. And so we decided to bite the whole apple, not just take one bite of the apple, and rolled it out across. So as Kim indicated, we came down to 3 sort of types of assessments, and I want to frame that as we then talk about the faculty development challenges. So one are the student-driven assessments. So these are the ones where the student puts the device in front of the faculty, in front of the assessor. It works well with things like procedural skills, direct observations of physical exams and histories, some of our interpersonal communications. Again, driven by the student, which means the students need to understand the system. It needs to be on their devices. They need to be competent in these assessments. Unfortunately, the faculty that are given student-driven assessments need to be competent in doing the assessments well. So even though it's student-driven, it doesn't duck our sort of expectations that our faculty understand the process and be knowledgeable and capable. We also have faculty-driven assessments where faculty can download the app and pull the app up on the iPhone, iPad, and Android, as well as with web applications. We found that this works in certain areas, but for most of our clinical assessments, it's really been student-driven. I would say if we had to compare getting the faculty skills up to a reasonable level versus the student skills, pick students all the time, okay? It was a lot easier to give faculty some basic skills and invest in having the students be capable with this system than vice versa. And then lastly, what we call device-driven assessments. And this works in areas like practice skills assessment, ground school practical exams where we could set up a device and the folks in the assessment theater, so to speak, all can utilize the same device to record the assessment of the learner. So in terms of implementing such a multi-assessor system, obviously the decision's the big one. And I think, took reasonable time making a decision. We certainly had multiple conversations in Myprogress. We did call some folks and talk to some folks that had done Myprogress, so I feel like we knew reasonably well what we were diving into. But it was really the implementation team led by Victoria Cannon and involving both medical education leadership, some core faculty, as well as our support team that really, I'd say, operationalized not just what we were doing with the forms, but what we were doing with the technology back end and pointing to what kind of development of our staff, our students, and our faculty would be required. I enjoyed Suzanne's frankness when I asked her how much faculty development did they do in Minnesota with their clerkship. She went 0. And I said, well, we did like 0.1 maybe of what we should have done. We did do faculty development. We invited faculty to faculty development sessions with over 1,700 faculty, with about 1,300 being clinical faculty. We had probably a whole 100 that came, and we had 5, 6, 7, 8, we had multiple sessions. The faculty that came, of course, tended to be those who were very interested in medical education. And as we think about it, we probably have about 500 or more faculty that are actually doing assessments. So you can see that we did not reach even the majority of the faculty in terms of hands-on training. Nicely, we get all of the students. So when I look at our faculty development process, we could have had more sessions. I think what we found was more sessions we had, the lower the attendance. I think we sort of reached the people that really wanted to come. We did not invest in online training or a lot of work in terms of, say, videos and things like that. We had a relatively tight, compressed timeline for implementation. I also wonder how many would have watched such YouTubes, frankly. But again, because most of this was student-driven, we felt that the faculty development was a relatively lower bar. Student development, on the other hand, we have significant control over, and we could ensure with the work of our mobile services team that every student's device was up and running, tested. The students were able to show us that they could do it, and we could run some practice sessions where the students could pull it up and working with some of our team showed that they could make it work. Now, nicely in the first year in longitudinal practice, they're actually getting assessments out in the clinics that they're embedded into. So they could right away in that first year start showing that they could make the system work, and if they were not, we had opportunities to fill in the gaps with those specific students. So I would say one of our lessons is if you make it student-driven, your developmental challenges will be lower, but they're still substantial. And then lastly, system support. So Victoria, how many thousands of hours did the team spend on the backside, the infrastructure? Yeah, it might not be quite 10,000 hours, so they may not be experts yet by Anders Ericsson's term, but they're getting close. They're probably certainly north of 1,000 hours. And there's a lot of work on the back end that makes this system work that the students don't see, the faculty don't see, and the other assessors, say in the clinical skills labs, don't see. But clearly that back end formatting, reformatting, testing when things didn't work, trying to figure out, I know we had times when it didn't work and it was like, we're betting it's user error. Here's a faculty member that can't get it to work, but we got to assume that it's device problem, and then could it be in the back end, and could it be a glitch in the software? So every time we had a problem, it required almost a root cause analysis to figure out where the problem is. But I would say over time, as these complex systems that are good tend to be, we're having less root cause analyses of breakdowns because we understand how to implement it, and when things don't make sense, they tend to fit into patterns that we can interrogate and understand. So in terms of faculty development of this multi-assessor system, we did methodology sessions where faculty worked with their own devices. As I said, we did not have to buy a lot of lunches because not a lot of faculty were taking their time out to come. But we did do some demonstrations at sessions that faculty were at for, say, division meetings and departmental meetings. During our training sessions, we did have some video examples that they could work on the device to do a little bit of rater training, although since most of our rating is really present, not present, it was not as challenging as if we had done behavioral scales. Of course, we had Todd and his mobile services team at every live presentation to show them that we weren't kidding, that there was technical support, and if you had problems, we could help you right then and there, and it will come out one way or the other and try to solve your problem at the point of contact. And then we developed Myprogress champions. As Kim said, we started internal medicine, pediatrics, and part of the pilots was really identifying individuals that were going to be especially competent in the technology, be able to understand it, and be able to do some limited problem solving with their faculty. So when I reflect back on challenges, I think one of the biggest challenges in retrospect is a lot of our faculty would look at this and say, we're turning out really good medical students with these green cards. Like, why are we doing this? Why are we doing all of this extra work? And establishing a rationale for change and a need for change is a real challenge in these change processes. And then, of course, training over 500 faculty. As I said, all the students are sort of a captive audience. We can train those students, but getting faculty engaged in the understanding it, no less being capable, is a challenge. And then developing this culture of competency assessment. As Kim said, we changed the forms and the process at the same time, but in a bigger context, we changed the whole direction of our curriculum like a year ahead of that. So our faculty were still grasping, why are we doing all these assessments? And again, I think our faculty by and by would say, we're turning out really good medical students. Why are we changing? Why are we doing all this extra work? So this is just 1 year's worth of deployments. I wanted to show you again, the sheer volume as Kim identified, but in this 1 year, we had over 9,000 assessments done in the year 2014 to 2015. There's no way you can do this with green cards. And there's certainly, even if you could do it with green cards, there's no way you could ever make sense of those green cards. What this allows us with Victoria's team's work is to actually be able to look at the data and be able to interrogate it and start asking meaningful questions. One of the I think important observations Kim highlighted is that most of our learners, at least at this Part 2 level of their basic clinical clerkships, are competent in these basic EPA type activities. Now, competent because you've demonstrated it once, I would argue, not sure, I think we're stretching a little bit saying they were competent that day, that one time with that one patient when they were at their best. And we could argue, well, if that's what they could do at their best, isn't that great? But most patients would prefer that their doctor be competent every time they come in to be seen, not just on their best day and the best situation with the faculty watching them. So I think we have a long way to go to be comfortable that we're really turning out individuals that are competent in the variety of settings that they will have to practice in. But this is an important first start to that competency assessment journey by having this multiplicity of assessments. So to sort of focus on the change process, I always like to go back to dead Roman emperors, because they were so wise. Like Marcus Aurelius, can anything that is useful be accomplished without change? Well, we were really launching a major change initiative. Faculty acceptance. Again, our faculty didn't have a chance to say yes or no. We didn't put it up to a vote. There was faculty input, but basically, we have over 500 clinical faculty that are actively teaching students all the time that basically had to do this. And that's a challenge in change processes when you lay change on individuals. And as I'll talk about, I like John Kotter's 8-step model to change, and I'm going to frame in my final comments what we did in terms of the Kotter model of change and maybe where we could potentially improve it the next time we revise the curriculum, Victoria, in about 10 years, okay? Yeah. So, faculty comfort with technology. I think, as Jim said, he was surprised that some students were not that technically adept. We were not surprised that a lot of our faculty were not that technically adept. And particularly, again, the folks that tend to come to the workshops tended to be the more comfortable. So that's been a challenge. The student-driven part of it, the motivation. If you tell a student you need to be assessed between 1 and 3 times, my bet is the mode's going to be about 1.2, right? Right, Diana? Probably close, yeah. So what's the motivation for the student to get these competency assessments? Do the students really buy that this is important for their development? Are we really giving them chances to do deliberate practice, as Kim talked about? You know, we can assess you one time and you're good, and you know, if I was doing the high jump and I cleared 6 foot, which I never will, but if I did it once, I would not argue that I should be done my training, right? But that what's the student motivation to be assessed multiple times, no less one time? And then what's the value proposition for the learners? So common reactions to change efforts. I like Lewin's model. He was an industrial psychologist who conceptualized change in organizations and basically said you got to unfreeze first, then you change, and then you freeze or make it permanent. And when we talk about the human reactions to change, we've seen all of this in our faculty. You know, resistance, apathy, compliance, they'll do it, but with the minimal. Conformance, tell me exactly what I need to do and I'll do it. And then commitment. We don't have a good way to feel their forehead and know what temperature they are on this pyramid, but we've seen all types. And that's certainly part of recognizing that these are change initiatives, is recognizing that the individuals enmeshed in it are going to have varying reactions. And I love Woody Allen. More than any other time in history, mankind faces a crossroads. One path leads to despair and utter hopelessness, the other to total extinction. I pray we have the wisdom to choose wisely. So many of our faculty would say, you put me in a Woody Allen kind of moment here, but the show goes on. And we have to recognize that just like Kubler-Ross, Mark Conley has developed the 5 stages of accepting change model, where faculty or folks involved in change can be seen to go through things like shock denial, to anger, to bargaining, to depression, and then ultimately to acceptance. And the reality is that whether people fear change or embrace it, it still happens to them. They feel like it's imposed upon them. And our faculty were no different. And I think we also have to recognize that nothing is going to be perfect, and we don't expect it to be perfect. We would love it to be, but that's okay. So I think we need to make it clearer, and perhaps we could do better on this with our faculty, that it's okay that if you find little things that are not working, or if we decide to improve it, that's expected. And don't sell failure short in terms of making things better. Many of you have seen, I'm sure, Bourne's The Adoption Process, and there is an element of picking up on the innovators and early adopters and getting them on board. At least if the early adopters are working on something, it can work. But we obviously have bigger challenges when we talk about the early and late majority, and then the last bit of laggards are, if we could find ice floes to put them on and push them out into sea, that would be wonderful. But usually they're tenured professors, so you don't have that option. So we recognize that during these change initiatives that we're going to have folks across this continuum. What we'd like to do is push it to the right. I like Nadler's comment, change is persuading massive numbers of people to stop what they have been doing and start doing something that they probably don't want to do. And again, I think that's the framework we have to take when we make improvements in medical education. So finally, in Kotter's 8 steps for leading change, he starts with create a sense of urgency, creating a guiding coalition, developing a change vision, so clarifying how the future will be different from the past, communicating the vision for buy-in, empowering people and removing barriers, generating short-term wins, early wins, then don't let up. So keep going and consolidate the gains, produce more gains, and then make it stick. And I think it's a useful model because ultimately leadership is getting others to do what you want them to do because they want to do it. So if I take a look at opportunities for more successful change implementation, I think we could have done a much better job of establishing a sense of urgency. I think, I'm not saying that's easy. In fact, the burning platform is probably the hardest part of change initiatives. But how to make it clear to folks that what we're doing now is not acceptable. What we're changing is not us, even though it is us right now. We want to be something different. And getting people worked up, excited, alarmed, at least in some way emotionally connected to the fact that we're making a change. I think another thing, we had a very good guiding coalition that were developing the change and developing the system. I think we had a clear shared vision. I'm not sure we communicated it as effectively with the faculty as we did with the students and staff. Empowering people to act on the vision worked well, and we've already made improvements and we've made adjustments as the plane has been flying. I think we probably could have done a better job of braying about the short-term wins and how well people were doing. I think when you're so busy making change and continually trying to improve, sometimes you got to step back and say, wow, we actually accomplished something. We got 9,000 assessments done. That's amazing. If we'd had 9,000 green cards, where would we be? And then consolidate and build on the gains. I believe we're doing well. And then institutionalizing the change, I believe, I cannot imagine us going backwards. So I think in that sense, this has been institutionalized. And then one of my other favorites, Machiavelli, there's nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. So I think that's what we need to remember as we embark on these change agents. So final thoughts, all change involves personal choice because ultimately we're dealing with people. The relationship between change and performance is not instantaneous, and we need to make that clear. It's not always like better right away. We need to make sure that people understand the strategy behind change. As much as they're willing to engage in the change, they need to have some idea of why it's happening. And then ultimately, involvement is what breeds commitment. So getting people involved, getting in their face, selling it, and then having trials, for example, all done well engender more commitment. And then any good change effort results in an increased capacity to face further change. And in a way, we're building the social capital of our faculty, and I would argue of our students and staff by going through such a significant change activity, which I think will position us well for future improvements in what we're doing with education. So I'll leave you with some change agents and what we really get excited about around here, which is Saturday night football. So I'll be happy to take questions. Yes?
Did you give the students the opportunity to change how they assess the faculty?
Student assessment of faculty. Cynthia?
They do not do a direct observation.
Yeah.
But I like that idea. Our students actually do very detailed evaluation of
Yeah.
our faculty in a behaviorally anchored way,
Mhm.
including whether they get constructive feedback,
Yeah.
active feedback, avoid ridicule and intimidation, and all of those good teaching behaviors. What did you have in mind about
I think that we all face the difficulty of having back
Yeah.
in, and
Yeah.
if there's change, if they're facing change as well, then talk about a sense of urgency.
Yeah, I'm kind of ambivalent on whether that would have made faculty engagement even tougher. But I can tell you, we're using, we do not have, in my view, as good of a construct of evaluation of the faculty as we do of the direct observation of these kinds of clinical performances. So we are trialing faculty teaching milestones at our children's hospital based on the Stanford faculty teaching competencies. And I can tell you in working with the 200 plus faculty at Children's, they get it. The construct makes sense. The milestone assessments, we're having challenges with our residents because the 5th level for these different Stanford-based milestones, like our best faculty don't do, but some reason the residents think that the hoi polloi faculty do them, because they're to the right. So we still have grade inflation, but I think the construct makes sense. So I'm more optimistic that over time we could have our learners as raters become more discerning with what they provide. Yeah. Yeah. Yeah, students are certainly involved in the pilot, and they continue to be involved in terms of making improvements to the assessment forms and to the process as we go forward. Yeah. Yeah, but faculty, assessment of faculty with such a robust system, multiple assessments by multiple people, we sort of do it, but it's very much not in as clear a construct. Other questions? Okay, so pull out Kotter the next time you're going to improve something, and remind yourself that you're really changing lots.
Many thanks, John. Thank you.